The next session is, I think, to continue what we already started to discuss, lasers, thulium YAG, holmium YAG, and the thulium fiber from physics to practice. And the debate starts by a state-of-the-art lecture of Dr. Alba Sierra del Río on, well, how lasers work and the importance of the parameters.
Hi, hello, thank you very much for the opportunity to be here today. And let's continue to talk about lasers. Oops. Okay. So the thing is that with all this technology and just one laser fiber, how we can be so versatile that we can treat even stones, tumors, prostates, or even urothelial stenosis. I'm not going to talk into detail with these three new technologies because we are going to talk about them later in detail. But let me say just some things that we already know, that all of them have different water absorption coefficient. And the peak power of all these three technologies is different, which led them different characteristics that we see later. So now the thing is that in the era of high power lasers, how should we perform? If we trust into companies, you can see that there is not a clear consensus on what we have to do according to our presets, and what's more, there has been some requires, and they are forced now in the second version to change their presettings because there were some complications associated with them. And if we look into experts, you can see also that there is not a clear consensus on that, and also what is more important, it's according to the surgical technique, and it can change over time. So it's not an exact parameter that we keep along. So is it you that you need to understand how laser works? And we are going to try to look for that. In Knoll lasers, you have a similar screen like this, in which you can choose the energy, the frequency, and the length of the pulse. The energy is the amount of light that we are delivering in a single pulse. So according for a stones treatment, if we want to produce bigger or smaller fragments, as we've seen before, we will reduce the energy if we want to dust, or we will increase the energy if we want to produce bigger fragments. We need to adjust this to our surgical technique and to the stone hardness. If it's a hard stone, we will dust it with a little bit more energy. The frequency, it's the cycles per second. So in terms of stones treatment, it will be the velocity, the speed that we are going to use to treat our stone. If we reduce the frequency, we will be slower. If we increase the frequency, we will be quicker. But be careful, because also we need to adjust this according to the characteristics of the stone. As you can see here, if we increase so much the energy, we will have this snowstorm effect, and it will impair our vision. The energy and the frequency will give us the total power. And this is really important because what is related is straight directed to the temperature. So heat, the production of heat, it's a matter of interest that we will take into account later. And the third thing that we take into account is the pulse duration, is how we deliver the energy that we have already chosen. As you can see here, this is cycles of 5 seconds. This is not in real practice, but just to demonstrate you. And the energy is delivered in the first second in a short pulse, and it's delivered the same amount of energy it's delivered in a longer period of time on the image on the right. So this gives us the next concept, which is the peak power. With short pulse, we will deliver all this energy in a short period of time, and with long pulse, we will deliver this energy in more time. For stones, this has a major impact in the retropulsion. As you can see here, with longer pulses, it will be less retropulsion. The short pulse will be the increase of the peak power and will force more fragmentation. So now, okay, we have these concepts. Let's imagine the ideal situation that we are facing now with new flexible digital single-use endoscopes, the use of all this new laser technology with pulse modulation. Also, we have these irrigation aspiration systems that we have already seen in the live surgery, and we are in the very beginning, which improve the quality of our vision. And we have this stone sense technology that we saw in the AUA meeting this year, in which is the implementation of the artificial intelligence, which identifies if we are facing the stone or the tissue. So with the combination of all this technology, we can imagine that now we can push our lasers to the maximum. We can use the high power laser settings by increasing the frequency. It has already been published that it will improve the efficiency, it will reduce the operative time, and it will improve also the stone-free rate. But unfortunately, we are not now living the ideal situation. We have a significant percentage of stenosis after our treatment. Also, there are some patients having residual fragments, and there is still an important significant risk of sepsis. For now, irrigation and suction settings, as we've seen before, is widely variable. We can choose different irrigation parameters, while we can choose also different suction devices. They, for now, are independent. So, as we don't have this irrigation aspiration control, the stone sense technology is not still available, maybe we cannot use this high power laser technology. Let's see what bibliography says. There is this recent systematic revision in which they were comparing 10 studies, comparing high power versus low power, with 2 different populations and 3 different surgical techniques. They conclude that we are able to use up to 60 watts in all 3 kinds of technology, with shorter operative time, better stone-free rate, and comparable complication rates. I think that all of you will agree that with PCNL and cystolithotomy, the irrigation flow, it's high, we have optimal visibility during the surgery, and there is an efficient dissipation of the thermal energy. But what about retrograde intrarenal surgery? If we look into the details of the studies that were pushing for high power laser settings, you can see here that it's because a significant reduce on the operative time. But they were using 60 watts in the ureter and in the kidney. What about the total energy use? It will be also interesting to know in this study what was the dissipation of the energy that they were using by fragmenting the stones. And also, as Professor Traxler says before, it's important that they mention that in the high power settings, they were using burst. The laser activation was in burst of 10 seconds, while in the low power was this continuous laser activation. This is mentioned in the other 3 papers that were supporting the use of high power laser settings for retrograde intrarenal surgery, in which to reduce the temperature, they were incrementing the irrigation rates, doing an intermittent laser activation, and doing short firing durations. This is known, as we have seen before, as the burst lasing technique, which has also been studied, as you can see here, and with the same total delivered amount of energy between the 2 groups, the continuous and the burst, by only reducing the time that we were activating the laser. You can see here that the pedal in the continuous group is constantly pressed, while in the burst, we stop the laser, we let the media to refresh and to all the debris go down, and then we reactivate again the laser. So at the end, we conclude that they were more thermal injury in the burst group. So this is something to take into account. And what about the low power? As you can see here in this study, even if we try to increase the irrigation with 40 watts, we are not able still to refresh the media with a proper irrigation, because the temperature is quite significant when we are using this high power technology. So, according to literature, in renal stones, we are established at 20 watts in the kidney just to control the temperature, and only 12 watts in the narrow ureters. So the conclusion is that for PCNL, cystolithotomy, we are able to use these high power laser settings now with a technology that we have available, but with retrograde intrarenal surgery, we are kind of limited now, unless we don't improve the suction and the irrigation devices, and we are limited to 20 watts in the kidney for now, and 12 watts in the ureter. I will let you now with my colleagues that they will discuss about lasers, and they will go into more details. Thank you very much.
Thank you very much, Alba. So please stay on the floor, and I would ask these 3 handsome guys that we just saw to give us their opinions on different lasers. I think you are the first, Ioannis. Yeah, good.
Good morning. I'm Ioannis Goumas. I would like to thank very much Javier Romero and Otero and Dr. Bozzini for the kind invitation. So I'm going to talk to you about the pulsed thulium YAG laser. How do I change the... Can you please explain me how can I advance the slides? This one. Okay, thank you. So, when we're talking about the thulium YAG, it's something different than the thulium fiber laser. It's a crystal laser technology, and it's similar to the holmium YAG. It uses a crystal, the same crystal as the holmium, but it has a different air cooling. This is important to understand the ergonomy and the energy efficiency of this laser. Commercially, there are available 2 devices, and one is working only in pulsed modality. The other one, it can work as a continuous wave or as a pulsed wave. So in the first thulium YAG was only continuous wave. Now we have more versatile devices. The difference of these 3 lasers is based on minimum differences in the wavelength. They're all infrared, so they're absorbed into water, but still minimum differences in wavelength produce very different effects in the clinical practice due to the coefficient of water absorption. And as you can see, the thulium fiber laser is the most absorbed in the water. The holmium is the least absorbed, and the thulium YAG is somewhere in between, and this is very important. The other detail important to understand, we saw this slide before, it's the peak power and pulse duration concept. These are concepts that we must know when we have to choose which laser to use in our clinical practice. And we see that the thulium YAG, the pulsed thulium YAG, is somewhere in between the TFL that has the lowest peak power and the holmium YAG. Now we know also that we have a holmium YAG, some 1 year maybe, that produces also very low peak power. So this slide is not updated actually. And these are the differences in a table. So the pulsed thulium YAG is somewhere in between as a wavelength and as a pulse duration and as a pulse peak power between holmium and TFL. What does this mean? We will see. Second thing, the difference between the holmium and the crystal lasers, holmium and thulium YAG, it's also the energy efficiency, the space and noise. The TFL, it's the best from this point of view. It's very small, and it's a normal plug. The same with the thulium YAG. It is a little bit bigger than the TFL, but you can connect it in a normal plug also in this room. It doesn't fit this to the holmium YAG high power. They come, the 2 commercially available pulse thulium YAG come with some presettings in one machine. I will operate now with one with the Thulio from the Dornier, so we'll talk about the settings. And the other one, the Revolix, it has different modalities with continuous wave. If you use pulsed modality, you have different combinations to adjust also the duration of the pulse and the peak power. We performed a review, the first review about these pulse thulium YAG lasers. Back then, we only had experimental studies. So this is the conclusion that the pulse thulium YAG has lower retropulsion forces compared to the holmium, better dusting capabilities than the holmium, efficient fragmentation of all types of stone, better for sure than the TFL, and the thulium and holmium YAG share similar risk profile in temperature of temperature changes. In the tissue, it produces less carbonization, less trauma. That means more smooth, the cutting effect, and features the most controllable behavior with increasing the laser power. It is more predictable. This is the first flexible uteroscopy with the pulsed thulium-YAG clinical study. It showed that it is very efficient, and it introduced the mucosa safety concept. That's one advantage for the pulsed thulium. If you hit the mucosa during the flexible uteroscopy, due to the coagulation properties of the thulium, due to the better absorption into water, you don't have bleeding. And so you have always clear field vision. This is the first PCNL clinical study from Germany, and they demonstrated also that it can be safely and effectively performed during the mini PCNL. This is the enucleation study that we performed, the first in the hybrid thulium-YAG, and we concluded that it is feasible and effective. And this is the other study, or the other pulsed thulium-YAG from Fribourg, Dr. Miernik, that demonstrated that the pulsed thulep is safe and effective, both published last year. And this is an editorial by the German guys, thulium pioneers, concerning the enucleation. That's, of course, it is on the surgeon's preference. It is energy independent, the enucleation, but probably the thulium-YAG, due to its physical properties, it is the most versatile. So conclusions, the new thulium-YAG is a universal high-power laser. You can do stones, you can do BPH, is space and energy efficient. The preliminary evaluation demonstrated great efficacy in lithotripsy and more predictable behavior in cutting the tissue. But of course, we need more clinical studies in the future to evaluate the real superiority to other lasers. Thank you very much.
Thank you so much. Perfect. Can you sit with us, please?
Yes, no.
Okay.
You're excused.
Don't worry. We are moving to the next speaker, that is Dr. Cesare Marco Scoffone, and he's speaking about the holmium-YAG laser.
So first of all, thank you to all the organizers for inviting us again in this really fantastic course. And my task today is to speak about holmium. I want to precise that I like also TFL, I like also the pulsed thulium-YAG, but I think that holmium, this is my conflict of interest, and holmium is the most historical laser. We have holmium in the guideline. We have for stone. We have holmium in the guideline for BPH, differently from TFLs and from the thulium-YAG that are really more new laser. And I want to underline the versatility of the holmium. And also for all the other pulsed laser, this is the characteristic that can these lasers can be used in lithotripsy, in enucleation, in soft tissue, in upper tract tumor, and so on and so on. And you know the characteristic of the holmium. I want to try to underline that is really important for the new urologist to know everything about the laser characteristic, the laser features, because it's really important to adapt our technique to the laser that we are using. So when we start to use holmium, we have two parameters to be defined. One was energy, and the other one was the frequency. And for the energy, increasing the energy of the holmium, we increase also the shape and also the bubble diameter, so we have more photomechanical effect. You have to know that this laser has this pressure from 7.5 to 26 bar, so able to break the stone, but also moving the stone up, so the problem of the retropulsion was really a problem when we started to do this, and also increasing the frequency. You have to know, and I really underline the safety way to use the laser. Don't increase too much the frequency, because with increasing the frequency, you decrease this time in which you can decrease the temperature inside. And as you can see here, if you increase the energy, you have more retropulsion. And when you increase the frequency, you have to take care, especially when you are using this in the papilla or into the ureter, you increase this thermal damage. So I underlined what Olivier told before, that the right frequency is between 12 and 15, also to allow you to follow in your fragmentation, in your dusting, because you decrease also, you maintain this snowstorm effect at the level that allow you to follow in your dusting. And when we speak about the modulation of the distance, we know that holmium is efficient till 2-3 millimeter from the target, so we can also modulate this distance from the target in order to try to decrease this really strong effect, especially when we are facing with this kind of machine. The first machine, we are facing with very soft stone. You saw in the previous live surgery that sometimes the energy of the holmium is too strong, so it's very difficult to dust really the stone. So modulating the distance, you can decrease this really strong effect, and this can happen also in the soft tissue. For example, holmium, you can use holmium with this really good photomechanical effect in doing enucleation, in the part of the enucleation in which you don't need to cut, but you have to divide the space in order to follow the plane. And also for the stone, you can use this in the contact mode, but when you use this in the contact mode, you are using the water that is inside the stone to make this explosion inside. And when you are using no contact mode, you are using this bubble that is creating on the tip of the fiber. And as you can see here, you can have different peak power, and this is the third parameter that in the last 10 years we are using. So we can increase the length of the single pulse, and increasing the length, we decrease the peak power. And for the holmium, this is mandatory, because the peak power of the holmium is from 2000 till 12,000 watts. So we need to decrease this peak power, enlarging the timing. But we have now the pulse modulation. So we have a new machine with the possibility to have two bubbles, or a different shape of the bubble. And you can see here you have really a lot of different bubbles. What is really important for us, for you, is to know the clinical effect in soft tissue and also in the lithotripsy, because what we see this bubble, but what is really important to put this information in the reality, in your daily practice. And the last kid in our OR is this machine, is the magneto, and the magneto is an holmium laser, high power holmium laser, with inside the possibility to have also this pulse modulation, decreasing the peak power till 500, 600 with a TFL-like effect. And with this new technology, we can also dust with the holmium without this problem of having only a very, very strong, energy. And as you can see here, you can do everything. You can treat, I think, 80% of the pathology that you face endoscopically. and you have to try to be always really safe in your surgery, and in the same time maintaining the efficiency of your surgery in terms of timing, use of the OR, and also in terms of quality of your fragmentation and dusting. And I want to underline, to show you this paper that we published 2 years ago about putting the ALARA concept from X-ray to the laser. So we use the laser as low as we can go. In practical terms, we are using, for example, for the enucleation, now we are using 30 watts, 1.5 joule and 20 hertz for holmium, and 1 joule and 30 hertz for TFL. And this is, for us, enough energy to reach the same efficiency of the laser. So try to use and decrease your energy given to the patient, especially in soft tissue, but also regarding the temperature for the lithotripsy. At the end, I show you this paper that in which we are the referees for soft tissue and debating thulium YAG laser, TFL, and holmium. But at the end, what is really important is the knowledge. There is a lack of knowledge in technology. I think we are really fix more on the technical features of our surgery, but we have to know exactly all the features of this really good machine, able to increase the efficiency of our surgery and able to also to make min-invasive all our surgeries. So thank you very much. I want to invite you to our Congress in next October. And I want also to tell that the online subscription is completely for free for everybody. If you are not able to come in person, you can follow us on the web. Thank you very much.
The last speaker for defending TFL laser, Dr. Dmitry Enikeev, when you want.
Yes, good morning, dear friends, dear colleagues. It's my great pleasure to be here. And frankly, I think my colleagues, my good friends, Cesare and Ioannis, mentioned all the benefits of thulium fiber, but I will try to highlight them too. So today we use lasers. We cannot imagine modern the urological department without lasers. So all the surgeries, bladder cancer, BPH stones, cancers, ablation cancers, we use lasers. So, and maybe I would like, before I start to talk about TFL, in very simple terms to explain how lasers work. Because I think it will be very important to understand the difference between the lasers with that principle. So the basic principle of all lasers is always the same. Flash lamp pumps energy into the crystal between two mirrors. Energy increases, then one mirror is open, and energy goes to the laser fiber. So it's very, very simple. While the mechanism is always the same, lasers differ in their crystal. And each crystal has its own wavelength. And the wavelength determines whether energy is absorbed by water or by hemoglobin. So today, all the lasers that we use in our urological practice, their energy is absorbed by water. And a little bit later, I will explain why it is so important. So lasers which energy is absorbed by hemoglobin, we use them for cancer ablation. Previously used them for green light laser, is also well known for vaporization. But now all the lasers, their energy is absorbed by water. Another important thing that's also important to understand the difference between all the lasers and understand that the advantages of thulium fiber, that there are two different operation modes. It can be continuous when energy hits the target and pulse when it fires intermittently. So we also need, most of the lasers that we use now, they are pulsed, and I'll also explain why. So why do we need crystals which energy is absorbed by water? And to answer this question, we conducted a study. So here you may see the picture of the real kidney stone. And you may see that it consists of many, many pores. And there is the water between these pores and outside the water. So there are two mechanisms of actions. So what Cesare mentioned, photothermal mechanical effect. So at first, energy hits the stone surface and the water inside the stone. It makes it brittle. And then mechanical effect destroys the stone. Having appeared more than 25 years, 30 years ago, holmium-yak laser quickly became a king of soft tissue surgery and lithotripsy. In middle 2000s, thulium-yak laser was appeared, but as Ioannis mentioned, at that moment, the main problem that it was continuous wave mode laser, and it was not possible to use it for stones. So, and when we talk with the experts of thulium-yak laser at that moment, they say which laser is better to have in the department, thulium-yak or holmium-yak. They always say holmium-yak because if you have patient with BPH and bladder stones, you have to have two lasers in your department. Thulium-yak for BPH and holmium-yak to destroy the stones in the bladder. So not each department can have it. Sometimes later, pulse modulation, so Moses effect, it's not something new. It was first described in 1986, more than 30 years ago. And now it got a second wind. So Luminis company, now it's Boston Scientific bought them. So Luminis company called it Moses technology, and other companies also have it in their systems. So very briefly, Cesare mentioned that, but I have my own pictures, and maybe I would like to, once again, to explain the difference between Moses and without Moses. So the laser without Moses, very simple. It makes a short pulse which creates the vapor tunnel. And energy goes to the tissue or to the stone. The laser with Moses effect, at first makes a short pulse, which creates the vapor tunnel, and then the second pulse, which goes to the stone and to the tissue. And this pulse, and this modulation has advantages in stones and in soft tissues. But now I'll try to talk about something else, something new. Welcome to the 21st century. And I think Ioannis also mentioned the benefits of TFL, but once again, I would like to highlight them. And this story starts in 2016 when we met with Valentin Gapontsev, a physicist and the head of IPG company, laser company, the biggest laser company in the world, located in US, in Marlborough, close to Boston. And after we met with Valentin Gapontsev, we started working on new laser. So at that moment, I was more than satisfied with holmium. I thought that this is the best machine ever I used in my life, and I was more than satisfied. And Gapontsev, as a physicist, asked me, what do you want from laser? What do you want from laser? And for that moment, I clearly understand what I want for stones, what I want for soft tissues, and we started that collaboration, and the first thulium fiber laser was developed in 2016. It was first described in 1910 by Nathan Fred. Nathan Fred works in the IPG company. And in 2017, during EU, we presented our first in vitro trial on TFL. And this laser, the first one, became the prototype for all other thulium fiber lasers in the world. So, guys explained the system of holmium-yak. I don't want to focus on that. What about thulium fiber? So it's very, very simple. You know, when I sat with my son, who is 17, he asked me, Father, can you explain the difference? So he's also interested in lasers. He said, can you explain the difference? So I said, well, he asked me, can you do the same work like you do with the old machine? I say, yes, I can do the same work like I do with the old machine, the same one. But what is the difference? And I tried to explain to him, can you print the text on the old machine, on the old big computer? Can you do that? You can. It will be the same text. Can you do it with a modern laptop? It will be more convenient for you. You can do it everywhere. You can do it quicker, some functions, additional functions. This is the advantage. So the thulium fiber, it's absolutely a new generation of lasers. New generation, new step. So it's, first of all, it's important, we talk about the wavelength. Let's look inside the laser. So inside, there is no crystals. There is nothing to be broken. There is a 30 meters of active thulium fiber pumped by a small diode laser as the laser source. That's it. Nothing to be broken. Another important thing that it has air cooling system in contrast to all other lasers that has water cooling. So it makes it lighter, more compact, microwave oven. So you don't need any special adapters to plug it. You just can easily plug it into the wall, and that's it. So frankly, what I do, I have it in private. When I go to the private clinic, I put it in my car and travel with the laser. Another important thing, and tomorrow we have live surgery of endoscopic calculation of prostate with thulium fiber laser, and I will explain, you know, seeing is believing. I will explain the difference between these two modes. It can work in two modes. The first is long pulse and short pulse. Long pulse, once again, I mentioned that this is a pulsed laser. It's not continuous wave laser. It's a pulsed laser. But we call this quasi-continuous wave mode. So it's long pulse looks like continuous wave, but it's still pulse, but it's very, very long. It's preferable for soft tissues, and I prefer to use it for soft tissues. It's not effective for stones. It's important to note. Short pulse, it has like Holmberg effect, and we can now clearly see that. Sorry, I will, oh, no, can we return back? Will be, yes, this big, yes, this big. For the stones, on the left picture here, you see the long pulse. So it's just ablate the stone. Absolutely not effective. Short pulse, effective lithotripsy. Vice versa on tissue. Here you can see the long pulse, effective, quick cutting, minimum carbonization, perfect hemostasis. This is how it looks like. And on the other screen, please, quickly. Yes, this is the short pulse. You see, it looks like the Holmberg effect. So it will be easier for the surgeons who work with Holmberg. It will be easier to continue doing the same procedures with TFL using this short pulse. So to be sure how it works, to check it, we did several very important experiments, and we invited Olivier to these experiments, did it together, and I briefly, just very, very quickly try to explain how it works. So, for example, to assess the efficacy of lithotripsy, how we can do that. So we invite physicists, we invite experts, sit together and think about the setup. In this setup, you can see the special cuvette with 1 millimeter mesh on the bottom. So we put it in another cuvette, fill it with water. Here you can see the inflow and outflow. Then we put beggar stone. Beggar stone is a special composition that we use for all experiments with the stones. And introduce laser fiber. And all the process was recorded with a high-speed camera. And we recorded it, how it works. And finally, we published it and found that in dusting mode and in fragmentation, it's very important, with high pulse rate, thulium fiber was 2 times more effective than Holmberg. Then retropulsion. And this is one of the goals. So we want for lithotripsy, we want less retropulsion. For that, we use another setup. Look at this. So there are 2 rules. All of this setup is inside the water. And here we introduce, in the middle, we introduce laser fiber. And all the process was also recorded with a high-speed camera. And we performed 1 pulse and recorded it and published also this study in World Journal of Urology. So we found that retropulsion with TFL 2 times less than with Holmberg. So it's an important advantage. Afterwards, Olivier Traxé even compared it with Holmberg with Moses. And even with Moses, retropulsion was less. Of course, we were also interested in safety. What about temperature? So high power lasers, thulium fiber. We also tried to assess it and to check it. So, and we found, we put thermocouples, for the first setup, we put thermocouples in inflow, outflow, and close to the stone, and found that there was absolutely no temperature changes, so it's absolutely safe. Found absolute regimens that is possible to use for retrograde surgery, for PCNL. The first prospective randomized trial was published by our Norwegian colleagues. They found the stone-free rate for thulium fiber in 3 months, 92%, in Holmberg 67%. Complication rate, less in thulium fiber. First prospective randomized trial in European urology. Now we have 4 meta-analyses on comparison thulium fiber and Holmberg for lithotripsy. All these meta-analyses, stone-free rate higher with thulium fiber laser. Olivier Traxé performed surgery with laser fiber 150 micron. Have you mentioned that? With Holmberg 200 micron, laser fiber is the minimum you can get. With thulium fiber, due to its technology, you can get the fiber up to 70 micron. 70 micron. And in the era when endoscopes are becoming smaller and smaller, we need fibers that would fit them. And thulium fiber gives us this option. Now we found that 150, for the efficacy, it's the same, but it has potential decrease particle size in lithotripsy, and how it is important in dusting era we know and we all perform this surgery. Soft tissues, the main topic, I love it a lot. Bladder cancer, en bloc resection, minimal penetration depth. The penetration depth of thulium fiber laser, 0.15 millimeters. With holmium yak, 0.4 to 0.7. So it allows us control the penetration depth. In bladder cancer surgery, it's especially important. So also several studies in reliable journals were published on this topic, and we found all the advantages of TFL in bladder cancer surgery. What about BPH? Tomorrow you will see it. Once again, all benefits, all advantages go to thulium fiber. What is really important, and today we will talk about BPH surgery in the evening, so glands more than 200, I will focus on that, but learning curve. If we talk about efficacy, thulium fiber, the same efficacy like holmium yak. For us, doesn't matter, but it's important for you, for people who start learning endoscopic evaluation of the prostate. And we conducted this study, it was published in Urology Gold Journal. I took 3 residents, electroenucleation, holmium, thulium fiber. With thulium fiber, learning curve was less due to its good cutting properties and perfect hemostasis. Tomorrow in the morning, live surgery, thulium fiber laser enucleation. So now we have meta-analysis. Once again, all functional outcomes, no matter you do endoscopic enucleation, thulium fiber, holmium yak, are comparable. So summing up, ladies and gentlemen, welcome to the 21st century. Thulium fiber laser, small generation, effective machine for stones and for soft tissues. Thank you very much.
Thank you very much, Dmitry. Unfortunately, at 10:10 we have to continue with live surgery. We have only 2 minutes for discussion. So I've got a question, and I should ask Ioannis, but he's not here, so I will ask the panel. The pulsed thulium yak laser, if we listened to his talk, is a bit of a laser that covers all. And my question is, if you look into the guideline for stones, only the thulium fiber and the holmium yak laser is mentioned or are mentioned. And why is not everybody buying a pulsed thulium yak laser if it's such a good laser? What is your opinion on this? I mean, you know the systems. You.
In my opinion, is really a young laser, so it's only 3 years that is in the market. So I think that this is the reason that we don't have papers on this laser. But I think I tried it for enucleation. I tried it also for stone. Is good, but now the time is really running fast. So he presented a very good presentation on TFL. No, I like TFL. But you are presenting papers and study comparing the TFL with the old holmium, okay? Because now we have Magneto, for example, that is completely different, and we have to stay update in everything. But what I want to underline to all the young urologists is that they have to know the characteristic, because when we started to do enucleation with the TFL, nobody can understand that it's possible. It's not only possible, it's really efficient, TFL in the enucleation, because you have to use in a little bit different way from holmium. So you have to adapt your surgery to the laser, but as usual, the driver, the surgeon, is really important. It's not the laser doing the surgery, but it's the surgeon.
I absolutely agree with Cesare. So regarding the studies, so there were also studies comparing with Moses, but once again, here we have absolutely, regarding thulium yak, I think it's the first data looks rather optimistic, you know, and we are all looking forward for other clinical trials, and I really think that it's the question of time. And this is like the market of cars. So when we have all different cars, we can choose, you know, and it's important to have this possibility to choose. And I think the future is bright for thulium YAG laser, new thulium YAG pulse laser. However, we go a little bit, in my opinion, a little bit back, make a step back after thulium fiber, but let's see, it's the question of time.
Can I comment only one comment, because we are speaking about the characteristic of the laser, but I think that in the market, and this is for the companies, it's really important to have companies taking care to the post-selling management of the laser, because this is the most important problem. Sometimes you have a problem, and now there are many companies that are only selling and not producing the laser, so they are not able. So I think that is really important also thinking about somebody that is helping you after buying the laser.